The lumbar spine lateral view images the lumbar spine, which generally consists of 5 vertebrae. Indications: this projection shows an orthogonal view of the APUPA view and is utilized in many imaging contexts, including trauma, postoperatively, and for chronic conditions. This view is also ideal in characterizing spinal alignment. Note: ideally, spinal imaging should be taken erect in the non-trauma setting to give a functional overview of the lumbar spine. Otherwise, patients with a suspected spinal injury must remain in the supine position without any movement. Patient position: the patient is positioned erect, supine, or lateral recumbent, depending on clinical history. In the lateral decubitus position, position the patient so that the humeri are extended 90 degrees to the thorax, with the elbows flexed so that the forearms are parallel to the thorax. Spinal curvature in the AP projection will determine if a right lateral or a left lateral is performed. When implementing horizontal beam technique, ensure the distal upper limbs are not overlying the region of interest. Ask the patient to cross their arms over their upper thorax, or to extend them in a similar position to that achieved in the lateral decubitus position. Technical factors: lateral projection. Expiration to minimize superimposition of the diaphragm over the upper lumbar spine. Centering point: the level of the iliac crest. Coronal centering point is directly over the lumbar vertebra, which corresponds to the posterior third of the abdomen. The central ray is perpendicular to the image receptor. Collimation: superiorly to include the T1 to L1, inferior to include the sacrum, anterior to include the anterior border of the lumbar. Detector size: 35 cm by 43 cm. Exposure 70 to 80 60 to 80 ma letters SID 110 cm grid. Yes. Image technical evaluation: the entire lumbar spine should be visible from T1 to L1L5AS1. Practical points: the 3-column concept of thoracolumbar spinal fractures is of particular importance when assessing this image for pathology. Utilize an erect bucky when performing horizontal beam laterals. To utilize oscillating grids, automatic expose control, and CR/IR alignment. If the patient demonstrates spinal scoliosis, ensure that the side with the convexity is closest to the IR. This will utilize the diverging beam and aid in achieving superimposition of the upper and lower end plates for particular patients. It is advisable to place a small radiolucent triangle sponge under the side, in contact with the table at waist height to reduce spine convexity. A spot radiograph may be required to show a clearer visualization of the L4 or L5OS1 articulation. Try to remove as many possible image artifacts, i.e. ECH leads, urinary catheters, especially when performing horizontal beam technique in a trauma context. If using a CR system, a smaller cassette 30 by 35 can be used when the sacral region does not need to be demonstrated. When centering, place the height of the CR to 5 cm above the iliac crests.